Oh, Shri, you're recording our group? All right.
That's right.
Pressure's on. Gotta represent.
I know. Good to see everyone. Yuri, Jason, Kayla, Kevin. Oh, we got a big group. Oh my God, the list goes on. All righty. Does everyone have the cases downloaded? Cool.
So let's launch in. Any volunteers to start reading the case, the beginning of the case?
Sure. Case 1. AY is a 30-year-old patient admitted with left leg cellulitis and overdose. They required several doses of naloxone by minutes and are initially admitted to the ICU for naloxone drip and IV antibiotics. They are initially somnolent despite the naloxone drip, but their mental status gradually improves by the time they are transferred to your acute care service. Question is, how would you start a conversation with this patient about their substance use?
This is the warm-up question. And with all of these, there's not like clearly a right or wrong answer. So, but how do folks kind of introduce that idea if you're on the wards, or in this case, on the wards?
Well, I've never had a patient like this ever. I'm just kidding. I typically start just by asking the patient why they came to the hospital, what events led them to that, and hopefully that leads to an organic introduction into the topic.
I like that, Kellen. I like the idea of starting with why they came to the hospital, particularly because folks typically, something like this, they're not coming to the hospital for treatment. Like, they might not want to talk about it. So I often find that, and this might be my own personal kind of bias because of my clinical interests, I also want to launch into that discussion about substance use and how that impacts the population, but folks might want to just get their cellulitis treated and not like talk about their substance use, which might be okay, And
I think sort of on that point, I then tend to segue in by just specifically asking if it's okay if we talk about our drug use. Because some people are going to say, no, I want to treat my cellulitis. I don't want to talk about my heroin use. Leave me alone.
Yeah, thanks, Gail. I think that's awesome. The asking permission is like, I think a very key thing. And for any sensitive subject, honestly, and it doesn't have to be a whole big deal, but just like, checking in and respecting the individual's autonomy about that, their preference. So. Any other tips or thoughts about how to open that conversation?
I sometimes will, if they're okay with talking about substance use after asking permission, just kind of gauging where they're at in their thinking, or like, are they somebody who's never thought about reducing their use before? Are they somebody who's tried multiple times? And then you can, if there's somebody who's like, I've thought about it, and then maybe you can start kind of tying in some of the benefits and consequences of their use, and getting them to think more about trying to stop use, if that makes sense. Just basically, are they ready to quit? Are they not ready to quit, etc.
Totally, yeah. And I think we'll get into that some with the next point. So it's a nice segue, Jason. I think, the conversation can be very different if someone, when you think about that stages of change kind of cycle, like if somebody's pre-contemplative, then you're kind of at a totally different spot than somebody that's like, oh yeah, I was like gonna go to Sound Mental Health tomorrow and enroll in treatment, but I'm here instead. So that might be a very different conversation. So you want to try to kind of suss that out as you start the conversation. Another tip I might have. I don't know if anyone else will ever do this. But when because I work on the inpatient addiction consult service sometimes at Harborview, and I feel like some of the learners that I've worked with kind of taught me this. Going in and asking, like, about someone's withdrawal, or like making sure they're comfortable in the hospital, I think can be a pretty patient-centered kind of way to kind of get your foot in the door about substance use. Potentially, it doesn't work for everyone, maybe, but I think that can be a good conversation. It kind of, speaking of Kellen's point, like it keeps the focus a little bit still around like their medical reason for their hospitalization. Like, we want to get your cellulitis treated, and we want you to be able to finish your antibiotics or whatever else you need while you're here in the hospital. Like, is there anything we can do to make sure that your withdrawal is managed, or things like that? So. Awesome. Should we keep going? Who else will help us read the next little section? We're in the second section now.
Oh, I'd love to. Let's see. They report injecting methamphetamines and heroin several times per day. They have not previously been in treatment. When you ask about their interest in starting medications for opioid use disorder, they say absolutely not. How might you respond? What factors do you want to explore with the patient?
Anybody heard this before? It's just substituting one drug for another. I think is what I'm trying to get at here.
I would ask them like what providers have explained to them about treatments for opioid use in the past, and see what, if any, education they've had about it before. And you could also, like, again, ask permission, like, do you mind if I share some information with you? So should you want to try these medications in the future? Do you have that information?
Nice, yeah, I love that. I think getting that information about the prior, experiences or understanding or perspective is really critical. Even if someone hasn't been in like formal treatment, they've probably had some interaction or some preconceived kind of notions about treatment options or the treatment system or something. So
I think I often ask people if they do you have any friends who've been on any meds to treat abuse disorder? Because I think either people have friends who've had positive experiences and you can do some great MI reinforcing of that, or they have people who have had negative experiences, and that's maybe a chance for you to provide some more information and counseling, and maybe give some more of that medical update of what the options are and what they're like.
Yeah, totally. Can anyone think of a specific example of late where that came up at all? No. What about the second question about stigma? Like, how do you think stigma could be playing a role in a situation?
Yeah, I think it's interesting to think about this label of opiate use disorder, and I wonder about the beginning part of this conversation, introducing medications, specifically like using language that's more patient-centered and saying, it seems like using opiates and methamphetamine has really impacted your life. It's really brought you here to the hospital. What do you think about that? And moving away from labels, I think, can be helpful.
Yeah, that's great. Catherine, it looked
Yeah,
like you.
I was trying to speak. I like what you said earlier about what people have said about making it part of their health identity, and just saying, like, while you've been in the hospital, you've been uncomfortable. Like, I know you've experienced this withdrawal. Here are some things that we've done to manage it in the past. And I've encountered the stigma and, like, people talking about their friends' experience with different medication assistance, and just like what having that on their medical record does for, like, how they might receive care in the hospital. So just, like, I think even having the addiction medicine service has helped, at least on the inpatient side, for me to, like, help patients feel like that's part of their medical care rather than, like, a special category that it puts them under.
Yeah, thanks, Catherine. That's good. I think I wonder if it can cut both ways. Like, folks feel like, oh, I'm kind of marked somehow because I'm having these folks come and talk with me about it. But also, I mean, the idea is to provide them extra support that they might need, be it from the nurse or the doc or the peer or whoever, on our team. That's a great, I think that's a great consideration. I think so many patients that I see have this internalized or self-stigma kind of narrative happening. And I think that's part of what I'm trying to get at here. And what to do about that isn't always necessarily super, like, clear cut, but at least kind of recognizing that, I think, is really, really important. And that's often, I think the other aspect I'll say is that often in my observation has been reinforced, that self or internalized stigma can be kind of reinforced when folks have negative interactions with the healthcare system. And the last thing I'll say is that I think it is hard to overemphasize that role of stigma in folks with substance use disorder. It's just it can be so, the guilt and shame can be so kind of overwhelming. And we don't always necessarily see or are not always in tune to that, partially because we're focused on the medical issues, and we're just on the other side of that pretty, big power or hierarchical kind of divide. So anyway, any reactions or thoughts to that?
I guess it's something that I think I try to explicitly call out when I talk to patients, not necessarily the internalized stigma, but the stigma in the healthcare system. That part of my conversation is often like, I take care of a lot of patients that use heroin or meth or whatever it is that they're using. And a lot of them have had really negative experiences in the healthcare system because of that. Is that something that you worry about, or is that something that you've experienced? Because I think that often gives folks a chance to say, like, yeah, every time I come to the hospital, all they want to talk about is my meth. And, like, I'm not here for that. I'm here for other things or whatever. And I think that often helps build rapport in a way that's really helpful.
Totally.
Yeah, just to sorry to interrupt, just to sort of echo off of what Kayla was saying. I think just sort of normalizing it for patients, and then I try to sort of think of ATC as sort of if you had a lung issue that you'd come in for, you would bring the pulmonologist on board, and this is sort of just like a specialty service that's sort of designed to treat these issues. And so again, just trying to normalize it as much as possible.
Yeah, that's a great point. Thanks. Yeah, I think the more we can kind of shift our colleagues, our patients and their families kind of perspective on SUDs, and shift it from that kind of the whole idea of, like, personal responsibility to, like, this is and it's not that there aren't it's not that we take away that individual's agency necessarily, but just shifting it into that kind of that chronic condition kind of mode where there are things that you can do, there are choices you can make, and there are other treatments and supports that you might need in order to kind of manage this issue. So, but it's, I think, because of, for lots of reasons, that's can be challenging for folks sometimes. All right, should we keep any other thoughts before we move on?
I have one other thought, Jared.
Yeah.
On that vein of what Yuri was saying and engaging consultants and normalizing it, I think especially on the inpatient services, really important to set your consultants up for success. I think there's so many time pressures in inpatient medicine, and we rely on the addiction consult service so much to have lengthy conversations about these things. But opening the door for them and setting the stage, I think, is really important, and something I have done poorly in the past. And then seeing the poor results as a result of that. So just one other thought I had.
Thanks, Ree. All right. Should we move on? Who wants to read our, now we're at the third little, it's literally one sentence.
I can jump in here. The patient continues to improve, but has been reluctant to discuss medications or other treatments for their substance use disorders.
So, great, thanks, Jason. How would you start a conversation about harm reduction? I think kind of shifting this, and then what harm reduction strategies would you consider discussing or offering?
I feel like I've been lucky enough to do the addiction medicine rotation, so I really like some of the language that we use when like meeting with patients in the outpatient setting about harm reduction, and just being like really a source of information about like the epidemiologic burden of fentanyl in the community, and being like, oh, hey, like, by the way, if you're using this, like, these are the things you might encounter, like, here's some test strips. And instead of like you're talking about a little bit earlier, emphasizing an abstinence-based approach, you're like, hey, like, these are things that I know that can help you because you've seen this happen to your friends. And people are super responsive to that. They're like, oh yeah, I definitely need some like clean cooker kits, or I definitely need such and such thing, and like I'll do that for my friends. Yeah, because you're there and you're not unwilling to talk about their use. It's like really helpful.
Nice. I like that, Catherine. Particularly, I like the, I think that the openness and the, that can go a long way with folks. I'll have to name the thing that's kind of that we might be uncomfortable naming. Like in this case, it might not feel always comfortably, like, but just saying, like, it sounds like, you're wanting to continue using, and that, that's okay. Is it okay if we talk some about, ways to keep you safe or healthier while you're using? I think that's okay to, most folks respond okay to that.
Even if someone's interested in reducing or quitting, I still like try to like say like, hey, but I think this is a great step, but we should be prepared, in case there is any future use. So I'd like to talk about some ways to make sure that's as safe as possible for you.
Yeah, I love that, Kevin. That's great. I find that conversation sometimes awkward, because the other conversation I'll have is when somebody's seeking treatment, like they're scheduled in clinic to start BUP or something, and how do you kind of thread the needle on wanting to encourage them with their goals around stopping using and starting on BUP, while also recognizing that they might not be successful, and here's naloxone, like I think that can be a tricky conversation, but such an important conversation to have. Anybody else have thoughts or suggestions around that?
Yeah, I think I always have a hard time threading that needle for that conversation also. And I feel like it's easy for patients to kind of get their back up then and say like, no, 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 I'm quitting. I'm quitting. And it's like, well, so I think the way that I often handle it is to just sort of say like, my job is to keep you as safe as possible. And I'm a better safe than sorry kind of person. And so just in case, because we're all human, I just want you to have these things with mixed success. So if anybody else has language they use, I would love to hear it.
I love that. And I mean, I think if we don't acknowledge and kind of address that, I think the other thing that can happen that I've seen happen is folks who kind of are expressing so much motivation and interest in stopping using, but then they do, go back to using, can, then that kind of reinforces that shame and makes them potentially less likely to come back and see you again at some point in their treatment. And I think setting that expectation early, like things might happen, and that's, it's okay. The most important thing is I want to see you. I want to keep working together. But I'm not the perfect example of what language to use always around that. But, I think that is a real phenomenon that happens. I like I'm a better safe than sorry person. So.
Sometimes just
Yeah,
like,
Kayla, sorry, good, Kevin.
Go ahead. I've talked.
No, Kevin, go ahead, please.
Okay, I was just gonna say like sometimes just normalizing like relapse is really helpful. Just being like everyone's journey towards quitting is different, and oftentimes people will experience relapse as part of their process towards quitting, and it's nobody's fault, and sometimes it just happens, and we need to be prepared for it.
Kevin, I was going to say the same thing. So great minds think alike. Yeah, just again, kind of normalizing that this is sort of like a chronic disease process, that this, isn't going to magically go away with, snap of the fingers. This is something you're going to live with sort of probably lifelong. And just like with diabetes, that there may be some fluctuations to patients' A1C, there might be some fluctuations to this. And again, just kind of normalizing that, it's not going to be perfect likely, and that there's might be some bumps in the road, and that's totally fine. And, we're here to support you through it. And yeah, we're here as a team.
I think there's so many parallels between like palliative care and communication training that we receive in harm reduction counseling. And we talked a little bit about like goals of care and understanding a patient's goals and their values prior to really jumping in and providing education. I think what I've learned to do, and I learned this in my third year, was to also share my goals. I think as Kayla was saying, like my goals are to really keep you safe. And then I like to lean on the like hope and worry language that I learned on a palliative care rotation. Like I'm really hopeful that this is going to work for you, and that you're going to be able to quit. But I'm also really worried about this. I'm really worried that this time around you may not be successful because relapse is really common. And this is what I'd like to do about that. So those are some language, specific language that I tried to lean on.
Nice. And I think that I love all that. And I think also, in looping the patient in and saying like, pointing out like, here are the hopes and here are the worries, and what would you like to, what do you think we should do about this? And trying to put that, build that kind of self-efficacy by talking about the strategies that they have to at their disposal to kind of support their recovery. So nice. In interest of time, should we see what happens after the patient leaves? Any volunteers?
I can read. The patient misses their hospital follow-up visit, but present to clinic 3 months later. They have continued using methamphetamine and have been taking blues, aka pressed pills containing fentanyl. They would like to start buprenorphine treatment. What unique considerations may you consider when discussing buprenorphine initiation?
Sorry for the grammar on the considerations you might consider when you consider.
I didn't even notice.
Okay, that's good. Yeah, but like, how are you going to help get this individual started on BUP at this point? This is the who was listening to Jamie's talk section.
Yeah, so right, you kind of explain, for the BUP induction, that you're gonna have to be sort of off of opioids for us to safely do this. Otherwise, we're gonna sort of precipitate withdrawals. And the concern with, this, whatever pill you're taking that could have fentanyl in it, it's just, those are especially dangerous, and fentanyl, especially a compound that can just be in there for a long period of time. And, we may think that it's out of your system and sort of start the BUP, and then you may sort of precipitate a withdrawal, and we'll just sort of have to deal with that. And again, just sort of, again, setting expectations for what it could look like, with especially kind of the fentanyl component, just making it potentially longer and more complicated, and maybe have to start and stop a couple times.
Is there any other thoughts? Maybe from someone we haven't heard from yet. Anything around dosing? Anything around no? Maybe.
Is this someone you could do like the micro titration thing?
I think it's something I might think about. So I haven't done it much in the outpatient setting. Thanks, Kevin, for bringing it up. That's what I was trying to get at. So, I think the regimens are pretty, the currently described kind of protocols are pretty complicated, like the dose is changing every half day or every day, which for many folks is challenging. And locally, I don't know if Jamie mentioned this, he mentioned that someone has, a couple of folks have, I think, published on like blister packing, but we haven't been able to find a pharmacy that's kind of willing to do that for us, because it involves like manipulating the films or tabs in a way not approved by the manufacturer, if that makes sense, i.e. cutting or splitting tabs. And so pharmacists have been had concerns about that. So I think it's something I would definitely think about, and many folks in the community are doing that already, are kind of recommending various schedules or protocols, and it's something that I think in the coming years we'll probably see happening more frequently, just because, like you already mentioned, like the withdrawal is probably going to be prolonged if this person's been using fentanyl pretty regularly for several months, potentially. There's going to be a lot of kind of bioavailable fentanyl, and it might take a while to go through that spontaneous withdrawal before they can safely start the medication. So the other thing would be dosing, like being more aggressive with dosing. I might, for most folks, we kind of get them to 16 milligrams a day, but I might have a pretty low threshold for bumping the dose up pretty quickly to 24, and we're even seeing some folks go higher than that, potentially. So
Would you ever consider starting someone on methadone as like a bridge until maybe the fentanyl is out of their system, and then try to start buprenorphine?
great question. So some folks are doing that, not with methadone, but with other opioids in the inpatient setting. In the clinic setting, I would be very, very cautious, i.e. don't do that if you want to avoid the DEA knocking at your door. So, but in the inpatient setting, there are some folks that are doing that. Actually, I've seen that described mostly kind of case series or case reports in the literature, transitioning to other forms. Sometimes folks are being put on fentanyl in the hospital, and then like kind of tapered down on that, and kind of cross titrated to other things, or other opioids. So yeah, I think that's a good thought, Jason. Thanks.
One other thought I had is I think that as buprenorphine is getting more traction in the community, people are using it differently, meaning that I think our classical recommendation is that we transition someone onto bup and then they take it regularly as maintenance therapy, but many in the community are using it kind of as needed for withdrawal symptoms, and there's a whole another like separate pattern of use that this person may be interested in, and exploring exactly what their expectations are and what they're hoping to get from it.
Yeah, I love that tree. Yeah. Is this something that the patient wants, as a pill in the pocket, kind of to reduce their frequency of use or intensity of use, or
Well,
film in
and I
the
think
pocket.
that has sort of changed how I have conversations about starting with people too, because increasingly I feel like I've had people who've tried it. They've gotten it from a friend when they were withdrawing once, and they've tried it before and they know what that feels like, which I feel like when I first started learning about this stuff was not as common for me. But often that is part of the conversation I have with patients too.
Totally. It's the rare individual, at least that I see at this point, that has really never taken the medication. Sometimes there are folks that have just taken it once or twice and had a really negative experience, and then you have that whole kind of discussion. Yeah, many folks have kind of pretty extensive. I definitely get the folks who are like, just stop talking to me about, like, I know what to do, don't just give me the prescription. And yeah, we'll go on from there, but nice. Should we go on to the last, in interest of time, should we try to get through this last little chunk here? One more volunteer.
All right, in the interest of time, I'll read again. Sorry, guys, I'm talking too much. The individual returns to clinic for follow-up. They've been taking buprenorphine for 8 months and continue to have urine drug screens positive for methamphetamine. Their most recent urine drug screen also contained fentanyl. How would you open the conversation about this patient's urine drug screen results? What changes to the treatment plan might you consider recommending? And if they would like medication treatment for methamphetamine use, which options might you consider, and what are the pros and cons?
Easy for less than 2 minutes. Who wants to tackle any one of those questions?
I guess in terms of the urine drug screen results, something that I have learned is that I never want to put patients in a position to lie to me where I'm gonna it feels like I'm trying to catch them in a lie. So if I know someone has a positive urine drug screen result, I never go in and say like, have you been using anything else? I usually just say, hey, I noticed that your urine drug screen is positive for these things. Can I ask you about that? Because it's this awful power differential. That's
Yeah.
a terrible dynamic.
Oh, yes. Yeah. We're not trying to trap people.
I agree with that. You don't want to shame them either, because you've created this, at this point, it looks like some sort of a bond or trust. And so you don't want them to not come back to you and continue treatment. So as we discussed earlier, you're going to fall off the bandwagon every so often, possibly. So I want to keep them there.
Yeah, again, just sort of just again, kind of just meeting patients where they're at. I know I think something that we kind of keep bringing up, but again, just sort of, like Kayla said, hey, I noticed your drug test is positive. What's up? Just sort of no judgment, open-ended, just, hey, what's going on? And then, that will sort of give you the room to then potentially talk about, fentanyl is really dangerous and it's in your system for a long time. And maybe there's ways that we can get you off of that or use that less, for example.
Yeah, you don't even know if that the fentanyl was a contaminant in their methamphetamine supply or anything. So just being open-minded and supportive.
Really, the urine drug screen is mostly, some folks don't even do it at all, but it's mostly there to demonstrate that the patient's taking the buprenorphine as prescribed, right? So that's the primary thing. And even if there's no buprenorphine in the urine, that just all that does, it doesn't say like, oh, you're not going to be with us. It just might mean maybe we need to talk differently about like how we're delivered. Do we need to do an injectable buprenorphine option? Do you need, should we do an observed dose in clinic and make sure that, it's working okay, et cetera. So, all right, too much for the time we had, but I really appreciate folks' contributions and engagement. So see you in a sec.
Yeah, thanks, Jared.
Thank you.